Hello and welcome everyone to our session today on Let's Code Together. My name is Dr. Samina Qureshi and I'm an International Medical Officer with the MSSO. Joining me today will be my MSSO colleagues, Hannah Eaton, who will help facilitate the session, as well as my co-instructor, Nicole Fornerato. Nicole, would you like to introduce yourself? Hi, Nicole.
Sorry, I was muted. I apologize. Hi, everyone. My name is Nicole Fornerato, and I'm a clinical associate with the MSSO. I'm based in northern New Jersey in the New York City area. I've been with the MSSO now about almost, I want to say 4 years. It's crazy, time flies. And I'm coming to you today. I like to always give a little weather report when I introduce myself, but I'm coming to you today from a very sunny, chilly spring East Coast of the US day. So yeah, and today we hope that you learn a lot as we go through some examples with Let's Code Together. So Samina, if you want to introduce yourself and continue on.
Certainly. So I've been with the MSSO. I'm an international medical officer, as I mentioned before, and Nicole and I have been partners in crime in conducting these Let's Code Together sessions several times. So some of you may have attended previous sessions. If not, we'll sort of begin and go over some of the basic instructions. Now, in order to be interactive with you, we are going to be using the Poll EV software, and at various points in the presentation, I'll prompt you to log in and to participate. Now, all of the instructions that I go over are available to you for your reference at any point in the session today in the chat section of your GoToMeeting panel. Now, I would also like to point out that the Q&A session that we will have towards the end of the session is intended to answer questions around those principles and exercises that we specifically discussed today, and not for general coding questions that you may encounter through your work daily. Now, for those very challenging coding scenarios in which you do have questions and you'd like some sort of discussion around, you will have the opportunity as well towards the end of the session to submit those verbatim terms for possible consideration in upcoming sessions of Let's Code Together. In fact, lots of the examples that you'll see today have been submitted from previous sessions of Let's Code Together. So you may perhaps see one of your requested examples discussed today. As well, I'd like to let you know that I will be performing my coding exercises and explanations using the web-based browser. I'm a bit partial to that. And we have provided, if you want to follow along with me, we have provided a temporary login ID as well as password for you to use in case you can't locate your own. That is also in the chat section of the control panel. Now, this session itself, I'm sure you're familiar when you signed up for the training, is going to last approximately 90 minutes. And in the unlikelihood that we don't finish, we always tend to carry over those examples to the next Let's Code Together session. So with that having been said, let's move forward. Okay, so now because we have people in the audience from varied backgrounds, I'll just give somewhat of a brief background in MEDRA and the framework around MEDRA. So just for you to know, and for very new beginners, MEDRA, the acronym, stands for Medical Dictionary for Regulatory Activities. Now, MEDRA is an ICH initiative, and ICH stands for the International Council for Harmonization. It was basically adopted around the mid-1990s. And since MEDRA is a living, breathing, and ever-evolving terminology, the ICH decided that someone needs to maintain this terminology. So they tasked the MSSO, or the MEDRA Maintenance and Support Services Organization, that task. So the MSSO further maintains and further develops the terminology based on user feedback, such as users like you will submit in change requests for possible inclusion of new terms. And so we provide that function, as well as we provide training, such as the one you're attending today, and we also administer the MEDRA licenses. Now, all of our MSSO activities are overseen specifically by the ICH's MEDRA Management Committee, and that committee is composed of various industry as well as regulatory bodies, with the WHO acting as an observer. So that kind of provides you a little bit of a framework on how MEDRA is set up. Okay, so now we'll go on the famous disclaimers slide. It's very verbose, so what I'll try to do is sort of summarize it as best as I can so we don't have to take too long on this, but we are required to review it before every presentation. So the first bullet basically just discusses that MEDRA is owned by the ICH, and all of the material that you will see today is owned and copyrighted by the ICH. Now, you are free to use this material in your organizations aside from the logo, but should you make any change or make any modifications, you are requested to acknowledge those changes and not imply that they are supported by the ICH. And the second bullet, I'll just read as is, that this presentation is provided as is without warranty of any kind. In no event shall the ICH or the authors of the original presentation be liable for any claim, damages, or other liability arising from the use of the presentation. And thankfully, the third bullet is not relevant to us because it speaks about third-party material, which this presentation does not have today. Okay, next slide. So for this, we do encourage, I just want to start off with saying that we do encourage that participants ask questions. And if you do have questions, of course, around the points that we're discussing or the specific verbatim that we're discussing, you are encouraged to ask questions and put them in the chat panel. And of course, if we don't get to your question for some reason, I doubt that will happen. We always make it a point, we have a record of the questions and we will get back to you through an email. Now, a very important point that Nicole and I always like to stress at the start of a presentation of this nature, in which there are multiple ways you can interpret the verbatim, there are multiple ways you can approach the coding question. In the interest of time, let's agree to disagree, right? We may not all agree on the specific coding choice that we have, but let's just agree to disagree. Now, specific coding requests, as I mentioned earlier, cannot be taken during the session. Of course, you will have the opportunity to submit those challenging verbatims that you encounter daily, and then we will try to incorporate those in the next Let's Code Together session. Okay, so we welcome you, we welcome your suggestions, and we'll try our best to answer all questions. Okay, so let's go to the next slide. And here I'm telling you how to join Poll Everywhere. So I'd encourage everyone, please, let's join Poll Everywhere so we can test if it works. Let's either use your computer or your tablet or your cell phone. Mostly people use cell phones, and go to this URL, www.pollev.com/NICOLEF, Nicole F. So Nicole is kind enough to let us use her Poll EV account. So everyone, please use this URL right now. I want to test with a few questions. And if you have a cell phone, I'd like to just, you can show your cell phone this QR code. It will automatically take you to the Poll Everywhere platform.
Yeah, and it's important to note that everything is anonymous that's done in here. And also, when you get prompted, when you log in, just click skip. No need to put a username. And Samina, sorry to interrupt you, but I just wanted to let everyone know I was having a little bit, to be completely transparent here, a little glitch with my Poll Everywhere today. So we hope that this goes as smooth as possible. And I'm just gonna have to take an extra step when we do our polls. Like right now, we'll start with where are you located, just test out. And plus, this is my favorite poll of the day because it allows us to see where all of our people who are joining this call today are. So, oh good, it looks like it's working. So my little glitch, my little workaround is going well. And Samina, look at this, it's filling up.
Okay, so yeah, as Nicole mentioned, don't hesitate when we're doing the coding questions to answer, because it's anonymized. We don't know who's answering. So you're totally anonymous when you reply, but certainly I see that people have logged in successfully into Poll Everywhere based on these green dots that are coming in. So we have a global, I guess, representation of attendees. I mean, we have people, lots and lots of people in North America, yet we have lots of people in Europe as well, India, all the way up over there. I guess my geography is not super, but we don't have anyone in the ocean. Sometimes we have pins in the ocean, so that's good. Everyone's on dry land.
Oh, there we go. We got a couple. Good.
Okay, we got ocean swimmers.
Yeah, this is my favorite slide because it shows the global representation of Medra and its reach, and it allows us, Samina and I, who are on the East Coast of the United States, to reach all of you today with a couple coding examples. Okay, so it looks like everything's working. What we'll do now is we'll go back to the presentation. I'm just going to deactivate this. Looks like everybody's logged in. See, usually it pops up here in my presentation, but today, so. All right, Selena, sorry, you can go back to your.
Okay, so just for your purposes, I would like to let you know that you can follow some of the coding examples. You have your option of using various MSSO Medra browsers. We have the Medra desktop browser, we have the Medra web-based browser, as well as the mobile Medra browser. Now, for your purposes, if you don't remember your login ID or password, you may use that provided to you in the chat section for your Medra web-based browser. And the URL to access that browser is circled right here in blue. The URL is right here, https tools.medra.org. So I'll give you a bit time to do those URLs to log into the browser when we perform the coding exercises together. Again, all of this information, passwords and temporary ID are in the chat section of the control panel. And here, for your purposes, here we've highlighted, dedicated an entire slide for you for this. Now, for those of you, it's too long to do the URL, just go to the medra.org website. And when you go on there, here's a screenshot, the home page. At the very top right, where the red arrow is pointing, we have a hyperlink WBB, the web-based browser. Just click on that and it'll take you to the web-based browser. And then you can log in using these temporary credentials highlighted in yellow that we have provided for you. So again, I will be using the web-based browser, so you can do the same as me and follow along. But like I said, you can use the other options of the MSSO provided browser, your desktop browser or your mobile browser. Okay. Next slide. Now, so with that information on how to log in and the temporary password, let's sort of get into and start the presentation itself. So I do want to make certain points, emphasize certain points before we begin on the specific exercises. Keep in mind that an exact match isn't always available, right? All the terms, if it were, wouldn't life be so much easier? We wouldn't have this Let's Code Together session, right? An exact match isn't always possible. There's always multiple approaches. And for that purpose, the Points to Consider document is a great reference because it always gives you options. One is always the preferred option, and then there's a corresponding alternate option on how to approach a particular coding principle. And of course, your individual organizations, the type of data you have, and whatever your purposes are, you can adopt the one that most suits your organization's needs. Now, it's very important, and sometimes we have a picture just to illustrate that point. The way I interpret data may be different from what my colleagues interpret it, right? Just like you look at a picture, I may see one thing, other colleagues may see another. So interpreting the data is extremely important. And now one baseline rule certainly is that assumptions should be avoided. Code only that information which is given to you. Don't add additional information by assumptions. By the same token, don't neglect to code what is provided to you. So don't omit as well as don't add information that's not there. Make your best approximation and use your medical clinical judgment. Okay. Next slide. Okay, so let's get ready. Let's, again, some of you are already logged in, but let's log into the poll everywhere. For your camera use, cell phone users, show this again to your camera, the QR code, it'll take you to Poll Everywhere, and then you just click skip, you don't have to put a username. Okay, next slide. Now we are about to start the actual Let's Code Together session with actual examples that are actually have been submitted by you in past sessions. So you may recognize this as maybe perhaps your suggestion. Okay, so the very first coding exercise or verbatim term on the next slide is, it's not working for me. Okay, here it is. Example 1. Here in the blue box at the top is the verbatim term, BP, in parentheses, blood pressure, high during dialysis. If you're given this verbatim, let's think in your mind, your sort of mental logic tells you, how would you code this term given this verbatim? Is it clear enough for you to code? What exactly, with this sentence or this verbatim string, what is being reported? You sort of start to think in your mind, which area of the Medra hierarchy am I going to look? What anatomical site perhaps, or which specific SOC is this perhaps going to be found in? And then you get very granular. What specific term or LLT will I look for? Okay. So now that you have that BP blood pressure high during dialysis, now's the time in POL-EV to put in how you would, which LLTs would you select to code that particular verbatim?
I'm going to just activate this now, Nina, and then allow them to be able to join in. Sorry, we're going to have this little extra step. So Samina, I might chime in every once in a while just to get this. So it looks like it's working, so that's good.
Okay, so some people would put high blood pressure high. Okay, now remember the verbatim said we're going very well. BP parentheses blood pressure high during dialysis. Okay, so people are on the right track. Blood pressure elevated, high blood pressure. Okay, so basically we have like consensus. Basically that's the how about the part, now let's think, what is all the information that's given? Blood pressure high during dialysis. Okay, so let me go to my browser. Let's pull up the browser and see how I would approach this. Now that we know what the audience, which way they're thinking. Okay, now of course, most people, because we have varied backgrounds and different skill levels in the audience, some people will just try to find an exact match and perhaps type in BP, right? And see, well, let's see, I have to do an exact match, right? And they found BP. That's blood pressure measurement. But our test, our verbatim said blood pressure high during dialysis. So that isn't quite complete, right? So some people said BP raised. Okay, and BP raised goes to blood pressure increased. Okay. Now our verbatim thing said BP parentheses blood pressure high. So then if I say, well, these are the things, I'm looking at things that say blood pressure raised. Blood pressure raised is blood pressure increased, right? Which if I open further is an investigation term, blood pressure increased. If I go specifically to, because remember our goal is always your ultimate goal is try to match exactly what the verbatim is saying. So if I say blood pressure high, because I want to match exactly what my verbatim string says, I found BP raised, blood pressure increased, which was an investigation finding. But if I go exactly by what my verbatim is, blood pressure high, I will find an exact match, okay? And that goes to PT hypertension. And that is not in the investigation SOCs. In fact, that is in the SOC vascular disorders. So then I'm thinking, well, how do I take this? Isn't a measurement of something always typically a investigative finding? But then I open up my points to consider document and I find otherwise, that this is an exception to the rule. So let's find out. Let's see on our next slide if we go to the presentation. Before we do that, I looked up for my own purposes. I said, well, I have a verbatim string blood pressure high during dialysis. Is there such a thing? Is that commonly found? So then I did a little checking. I checked my references. And then one of the articles I found actually, lo and behold, talked about intradialytic hypertension. And that is precisely defined with the way that my verbatim is. It's defined as an increase in blood pressure during or immediately after hemodialysis, or, you can assume dialysis. So going on to the next slide, I think, how do I code this? I found one term that was an investigation term. I did an exact match and I found that exact match. under the PT of hypertension. And I did my further research in referencing, and I found that this certainly is found the hypertension is found during dialysis. So do I increase it, do I code it as such? Do I even say it's a complication? Do I code it as hypertension? Do I code it as an investigation? Do I code it as an hypertension? Or is it something else even better that can precisely, accurately, and in one term capture what is being reported? So then, in order to help me determine, I go to my MEDRA term selection points to consider document. Remember I said it often has an alternative and a preferred option on ways to approach coding challenges. So here it's telling me it's precisely the little question that I have. The qualifier increase, typically the way I was thinking in MEDRA, refers to things from normal to high, from low to normal, and typically are investigative findings, right? But as I continue to read this, it does tell me the exceptions to this rule are as follows. LLT blood pressure high and LLT low blood pressure are linked to the disorders term or PT hypertension or PT hypotension. So in this instance, because of this finding in the MEDRA term selection points to consider document and the exception around blood pressure high, I can safely assume to interpret this as hypertension. Now, when I do that, then I will look in my browser again, if you can pull up the browser. Based on this, as well as based on my referencing article, that this, yes, typically hypertension is sometimes associated with dialysis procedures, I'm going to now make the assumption that the blood pressure high, because MEDRA tells me so, as well as the PTC document, and I'm going to look for hypertension just partially. And is there anything having to do with hypertension and dialysis? I don't know. Let's look. Okay, so here I see diastolic hypertension. That's not it. Hypertension diastolic, that's a type of systolic diastolic. I'm looking for, okay, here's something, hypertension during dialysis or dialysis-induced hypertension. So that goes to PT, dialysis-induced hypertension. Same PT, dialysis-induced hypertension. And I think I have a winner here because that actually in one term is giving me that principle which is in the verbatim string without having to split code and precisely using the PTC document, safely assuming that that term BP high, it can be interpreted as hypertension. So we go to the slides. And I'll go to the next slide. And the final suggestion or the correct answer is what we just looked in the browser. Using the browser, using our references, and the PTC document, we can safely say that the way to appropriately code this verbatim string is LLT hypertension during dialysis. Now I think this will probably prompt some questions, so I'll take any questions if there are any in the chat section. Any questions? Let's actually see.
And Samina, here's the updated
Someone
result.
did. Excellent. So basically people were on the right track. I do see some, exact matches, hypertension during dialysis. Excellent job. So if there are no questions, I'll move on to the second example.
No questions. Looks like everyone is clear.
Good. Very good. So point noted and take-home message has been delivered. Okay. So let's go to the next slide. And example number 2. Okay, so here's example number 2. How would you code this? So this is quite a bit of information here. Felt like his hands were as big as watermelons and feet the size of a quarter. The doctor said it was possibly like some type of a syndrome of Alice in Wonderland. My goodness, I bet some of you have never heard of this before. Hands as big as watermelons, this is what he felt. This is the patient describing what he's feeling. He felt like his hands were as big as watermelons and feet the size of a quarter. And then the doctor said it was possibly like some type of a syndrome of Alice in Wonderland. So is this verbatim clear enough to code? Sometimes you don't have the option to query, or even when you query, you don't get much more additional helpful information. And this is what let's assume this is what you have to work with. So I'm going to think, first of all, what's being reported, what is the SOC possibly I'm going to be looking for this type of, and of course we'll have more than one LLT, but generally where will I be looking? What is the most appropriate LLT, and is this a multiple, concepts in this particular verbatim? So let's go to the next slide. And now I'd like people to see, I just want to see how they're going to approach this. Which LLTs would you select?
Sorry, I have to
Given
pull
that
it over.
verbatim.
Switch it. Oh, there.
I think
we'll go into this one. We'll activate.
Okay.
So there you go.
Okay.
Let's see what
So
comes up.
everyone put in the LLT or LLTs because
I
they will have
apologize.
multiple.
Yeah, and I apologize. Some people started putting in the old link. So if you did that, just retype because we have this little glitch. So we have to kind of, it's going to always be just a couple seconds delay from when that slide comes up in the presentation till when I activate the new one, just FYI. Look at this, Samina.
Okay.
It looks like everybody's in cahoots.
So okay. People are putting it in. Okay. So this is, okay. So this is what other things, if any, would you put in? So now that we have a general sense that people would code this term, Alice in Wonderland syndrome, are there any other LLTs you would do? Another second or so to see. So basically, general consensus is the diagnosis itself, Alice in Wonderland syndrome. Okay, so let's go to the next slide. Now that we see what majority of people are saying. Okay, so first of all, the way I would approach this, and had I not been so smart as the audience, and I was not so familiar with this particular syndrome, I would look it up, first of all, right? We have lots and lots of references at our disposal, and I always encourage, especially when you're not familiar with a particular concept, to certainly reference it. And so in this instance, I looked up in Dorland's Medical Dictionary, and this is the way it's been defined. There is actually what the doctor possibly said it could be. There is such a syndrome, and people looked it up, and I did as well, and it is a delusional state manifested by depersonalization, alteration in the sense of the passage of time, distorted perception of objects, hallucinations, and other delusions or illusions. Okay, so basically this is the general description of the syndrome. So I go further to understand even more. I look at more references. On the next slide, it's sticking for me. Okay, so when I look it up, again, it's giving me even more definition. It's characterized by distortions of visual perception, metamorphopsias, the body schema, and the experience of time. Similar to what sort of Alice, if you're familiar with that fairy tale by Lewis Carroll. So basically, I keep reading it, and I do see that what is being described as one of the symptoms where he feels his hands are very big and his feet are very small. This is actually one of the signs and symptoms of this syndrome. It's distortions of visual perception. So I continue looking, and in that same article, they continue to actually list the types of visual distortions, right, or the metamorphopsias. Here, if I look and I'm looking for the one that matches what my patient reported, seeing on the last two, macropsia, seeing things larger than they are, like his hands, and then micropsia, seeing things smaller than they are, like his feet, which were the size of quarters. So that is actually the two types of visual distortions that were reported along with the syndrome. Now, a lot of you put in Alice in Wonderland syndrome because we're used to the preferred option in MedDRA, in the PTC, when you have a diagnosis, you don't need to always code your signs and symptoms, right? So a lot of people took that approach. So if we go on to the next slide. Okay, so here I'm just sort of explaining to you that these two things are what were reported by the patient. The micropsia, in which his feet looked like a quarter, and the macropsia, in which he felt that his hands were as big as watermelons. So anyway, we go to, oops, I'm sorry, I went too fast. Can we go back a slide? Okay, if we go in the term selection points to consider document, we will notice that the section 3.1 talks about definitive as well as provisional diagnoses with or without signs and symptoms, right? A provisional diagnosis is one that's usually preceded by possibly, probably, a suspicion of, and in our verbatim, the doctor did say he thinks it's possibly or probably Alice in Wonderland syndrome, thereby making the diagnosis a provisional diagnosis, right? And in the PTC document, the preferred option of a provisional diagnosis is to select the term for the provisional diagnosis as well as for the reported signs and symptoms. Okay, so having referenced that and the preferred way, which I want to adopt, of approaching a provisional diagnosis, we would thus code what most of you said, the Alice in Wonderland syndrome, as well as the fact that he was seeing his hands big and his feet small, the micro and macropsia. So next slide.
Samina, maybe before we go next slide, you want to take a look again what people are, because there's a lot of different.
Oh, they did. Excellent.
Yeah,
Good.
Lots of different options. So I figured I'd bring it back up for you so you can see.
Oh, thank you. I didn't see. I was blind to what they were responding.
Yes.
Okay, so good. So someone said follow up for more information. That's not incorrect. Good. Alice in Wonderland, body image disorder. That in this particular context, that would be incorrect. Okay, keep going. Okay. But this is good that people are saying that they would put, some sort of additional size and symptom, sign and symptom.
Yeah.
Okay. But having had the advantage of looking at the research or the reference, we specifically, oh, excellent, someone got the precise sign and symptom that was described by the in the verbatim string, macropsia. Excellent job. Excellent. Look at this one. Macropsia, micropsia, Alice in Wonderland syndrome. Absolutely wonderful. They got it. Perfect. Too bad it's anonymous and we don't know who did it. Sorry. It's anonymous. So good. So some people did follow the my thought process of capturing the sign and symptom as well as the provisional diagnosis. Very good. Excellent job. So let's go to the next slide. And here I'm telling you the final suggestions of the codes that we would choose. So the final suggested answers are micropsia, macropsia, and Alice in Wonderland syndrome. Any questions at this point for this second example?
I am not seeing any questions at the moment.
Wonderful. Okay, so let's go on to our third example. Okay, so can you move this next slide? Nicole, my mouse is not working. Okay, so here, again, I just want to emphasize, if you're not familiar with a particular, syndrome or a particular concept in medicine, always use your references. Also take advantage of using the Medra hierarchy of where that particular concept is placed. And of course, use your browser for the most exact match terms. Some of you did, and it popped up Alice in Wonderland. Who would have thought? And then, of course, make sure you refer to your PTC document on how to best approach either a definitive diagnosis or, in this case, a provisional diagnosis. Okay. Here's example number 3. This is the verbatim. She was nearly dead after her car accident and felt dejected because her husband died in the crash. So it's very important to look at each word and try to capture all of the information and not omit any information that is in this verbatim string. Okay, so certainly there may be possibly multiple LLTs to capture everything that's reported here. We look at the verbatim, we try to make sense of what's being given, what is being reported. We again go through our mental checklist. Which SOC would I look in perhaps to find these concepts? And then I get very granular. What concept, one at a time, would I need to capture? And here I see potentially she was nearly dead. I would definitely have to capture that. And then we want to take into account the circumstances after her car accident. So in my mind, in my mental checklist, I want to capture that somehow. And felt dejected, I do certainly want to capture that, because her husband died in the crash. Now, some of you will be very astute and figure out that that's also perhaps something to try and capture. So far in my own mental checklist, I would capture she was nearly dead, Try to somehow capture the car accident, felt dejected, and husband died in the crash. So let's go to the next slide and give everyone the opportunity to put in what LLTs would they select for this third example. So give a second or so for Nicole to activate it, and now start typing. Okay. Okay, so some people said post-traumatic syndrome. Someone said adjustment disorder. Remember, do remember that we try not to diagnose unless specifically the diagnosis is given. We try to do ultimately our primary first way to approach something is to try and find an exact match. Okay, excellent. Very good, very good. Someone has near-death experience. Someone has emotional dejection, because there's several LLTs in this one. Okay. Any other guesses for other things in there? So far, I see some correct answers. Dejection, emotional, good. Is that a LLT, crash-derived depression? I don't think so. Near-death experience.
I'm not sure either, Samina. So maybe you could check that one in the browser, right?
Yeah. So what was it? If you go down.
I'll go down.
Crash-derived depression. Okay.
Yeah.
So I would need for you to pull up the browser, and then I'll check crash-derived.
Okay. And while you're doing that, we'll leave this open and give everyone a chance to fill in their answer. Let me pull the browser. One second.
Crash-derived depression. Okay, so here is the browser. So let me do crash. Let me just put in crash and see. So actually that is not a actual LLT in Medra, so that we would not have that as an option. Okay, and someone put in, oops, near death. So let me try to find near death. Okay, so let's see near death. Near death experience goes under near death experience, and I would agree with that. So that is one of the correct answers. Good, because it specifically, we wouldn't say death because she didn't die, right? She had a near death experience. She was nearly dead, so that's a near death experience. Very wise of you to capture that, and that is the correct choice. And then other people also had, let's see, go back to the poll EV and see what else people had. A lot of them had near death. Dejection, emotional, because they captured how she felt, which is very good. Emotional dejection, emotional. Okay, excellent. I am very pleased to see people have motor vehicle accident. Good. And some people also have death of husband, which is, they captured that one. Very good. See, and this was actually a submitted one from our previous Let's Code Together sessions. This was an example that people wanted various types of death terms. How would they code them? And this is the way you would do it. There are deaths, there are near deaths, and then of course in social circumstances, let me show in the browser. If we go to the browser, let me just review sort of the death terms. Okay, so when we go under death, you should realize that there are several, look at 117 terms with the term death in them. And it's very important to see that the basic term of death is under the HLT, death and sudden death, going to SOC general disorders, right? Then you have various types of organ deaths. So those are different from a regular death. You have fetal death, intrauterine death. And then what I'm talking, what we have in our example, death of husband, right? Right here. The death of someone else related to the person is actually in SOC social issues, social circumstances, I'm sorry. So SOC, social circumstances, has the death of various relations, child, daughter, father, friend. So that death concept is different and is viewed as a social circumstance, whereas the death itself certainly is under general disorders and administration conditions. So you see the difference. You also have accidental death. Sometimes the nature of the death is important to capture. And you see that this is mapped differently in MEDRA. An accidental death is different. Okay? So very important to be familiar and how the SOC changes depending on the nature of the death that is being reported. And of course, as I mentioned before, you have various organ types of deaths as well. Okay, so let's go back to the PowerPoint. Okay, so very good. People have performed very well. They have the correct answers, a lot of them. So here I, again, used my reference to sort of get an idea of what is the difference. A near-death experience as such, as some of you have, has been reported by patients who have survived life-threatening conditions, such as cardiac arrest, trauma, suicide, surgery, etc. Okay, so and these self-report scales have revealed common features, and so the reference kind of goes into detail describing a near-death experience. Okay, and then of course we showed you in the browser the various deaths and how they are mapped in MEDRA, and of course the final suggestions on how to code this particular verbatim is, like the majority of you, the LLT near-death experience. Some of you captured the fact that there was a car accident with LLT motor vehicle accident. And of course, death of husband, which is related in the SOC, social circumstances. So those are the three things. And of course, don't forget your felt dejected. And lots of you I saw did capture that with either emotional dejection or dejection emotional, which is correct. Both are correct. So these 4 LLTs would be adequate to capture this particular verbatim. So you see sometimes, like in the first example, looked like a multiple concept, right? But we found an LLT that had just one term. And this one has all 4 terms to complete this example. And let's see what anyone else have. So good. So a lot of people have the correct answer. Good. Near-death experience, dejected emotion. A lot of these other things that people have, like adjustment disorder with depressed mood, those are diagnoses, and it's not really in the verbatim as such. So those would be incorrect. And yes, would you suggest splitting? Yes, we would. And we gave you the final suggestions with exactly that 4 separate LLTs to adequately code this particular verbatim. So with that, I think if we go back to the slide, this is the end of my 3 examples. I think, Nicole, if you want to start your examples.
Sure. Okay, and do you want to just go through your, or you went through your learning points, Sebastian?
Yeah, we went through these, what to look at, yeah.
Okay, all right, so now we'll start with example 4, which is my first example today. So now we're going to take a look at a case report that's centered around a patient mammogram. So as you can see, there's a lot of information reported here in this term or this concept or this, whatever you want to call it, case narrative. So as usual, we should take the recommended first steps by determining what exactly is being reported, what information will need to be pulled out, and what information will actually need to be coded. So are all the reportable concepts clear enough to code? Is there enough information for each part, right? When a report with a multitude of information is received, one of the first items to think about is how many reportable concepts are within this information, right? Because you get this big case narrative, especially when working in drug safety, you know, or academia or whatever, all different areas, you kind of get a multitude of information kind of thrown at you. And you have to kind of think through it and say, what are the steps I would take? So from my perspective, the first step that I would take is to determine, okay, what exactly needs to be coded? So before we tackle the actual coding of this report, let's determine how many terms or concepts we feel should be pulled, reported, and then coded. So everyone take a look at this term. I'll leave it up for one more second. And then I'm gonna open up the poll and we're gonna see that this is what I'm looking for now is the number. Oh, so I actually gave a true false. So you don't have to give a number right now, but I wanted to say, is this this narrative would result in a total of 5 concepts to be coded. Is that true? So let's take a look back. Give you another second just to have it up on the screen and get your thoughts together on if you think that will be true or false. If there's 5 concepts to be coded here. We'll pull this back up. Again, bear with me because I have to pull this over. And I'm going to go to the next poll. Where is it? Okay, here we go. And I'm going to activate this and see if people think there are a total of 5 concepts to be coded. Let's see if this is, if you think true is yes, false is no in this case. So let me know what you think. Looks like lots of people are saying false for this, that there should not be 5 concepts to be coded. We'll give a little more time for everyone to go through. I mean, to put their response in, and then we'll go through it. And again, this is kind of a first step. When you see something, you know, a narrative comes in, it kind of, you know, it looks a little overwhelming. You're not sure where to begin. What should be pulled exactly? We get asked this a lot. And of course, we can't provide like exact, you know, tell you exactly what to do in your day-to-day, but we can give you the tools kind of to go through and be able to do this yourself when you see something like this. So it looks like the poll kind of has stalled out. So I will move it back over. It's really annoying that it's not coming up in my PowerPoint, but it is what it is, right? So now we'll take a closer look at this term, right? So at first, you know, breaking it down, we say, okay, let's break it down. You can even say by sentence, right? But the first part of this term, the patient experienced extreme anxiety due to upcoming mammogram. So you could see, okay, yeah, I think this should be captured and coded, right? It's what they're experiencing. It's due to an upcoming mammogram, etc. So now we'll break the term down even further. We'll go to the next part, right? So, and this is kind of my process of how I break it down. I'll take it sometimes by sentence. If there's not sentences, sometimes you take it by concept, but just giving the idea of kind of how you would break it down to even before you begin the coding, right? Or sometimes it comes to you through like your case management group or whoever is doing this, but still you get an idea, and you can, if you reference back the actual narrative, you can see kind of an idea of what should be pulled. And again, this is based off of every organization may have their own rules or coding conventions around, or even data management conventions around, or drug safety, pharmacovigilance, et cetera, around what should be pulled and coded. But this is just to give you an idea of how I would kind of look through this and what I would do. So see the next part, the mammogram resulted in architectural distortion and small breast cysts. Okay, yeah, that looks like maybe one, maybe possibly 2 items, right, that should be pulled and then coded, right? So here I would say this is actually, in my opinion, potentially 2 items. Okay, and then we'll take a look even further as we go through the write-up, and you'll see here that there's a follow-up MRI that showed no suspicious tissue abnormalities, right? So that's the last part. So you can see there's another section of the report after this, kind of on the bottom, which I did not highlight. And you could see even on my next slide, it's not highlighted, where it states that there's a recommended 6-month follow-up MRI in 6 months. So this section was not highlighted as information to report or code because it actually contains a recommendation for a follow-up in 6 months. It's not reportable information, since there's nothing that has or is happening to date, right? It's just something in the future that the patient needs to kind of keep track of and go back and do. And maybe at that time, more events or more concepts will be reported that then need to be, you know, pulled out, coded, etc. So you can see here, based off of that and what we just went through, the correct response for how many concepts to be pulled is there are a total of 4 concepts to be reported and coded in this narrative that was provided. Okay, so now we'll go through, now we'll start to say, okay, we got the information we need, the reportable information within narrative or concept that we received. Now we'll go through how we should code them, right? How should these terms actually be handled? So what I'll do is, bear with me 1 second. I have to pull up the pull everywhere, but we're gonna go through and say, we're gonna select an LLT for the first part of that concept, right? Just give me 1 second. Okay, I'm gonna activate it, but the patient experienced extreme anxiety due to upcoming mammogram. Oops, sorry, there's a misspelling in there. I apologize. That there should be an O in upcoming. But let's see what everyone's thoughts are around this. Okay, I'll give everyone a little bit of time. Let everyone. All right, we're getting lots of responses, so we'll keep lots of similar responses here, actually.
We just had a question come in, Nicole, asking, where we have to code these concepts, they aren't ADR due to drugs. Result of mammogram is a test, for example.
Yes, so something like this may come in, it may be in medical history, you may have a procedural page that you want coding. I mean, it could come in many different areas. So this is not directly say, it doesn't have to be an adverse event. We're not bucketing ourselves into what to do. We're just giving examples of different types of things that may come in and kind of how we would, our process of how we would go through it and how we would handle it to code it. Are there any other questions, Hannah?
That was the only one we've got so far. If anyone has any questions, send them please in the question panel of your GoToWebinar control.
Yeah, great. All right, let's see here. So taking a look at this, okay, we see a lot of procedural anxiety, mammogram abnormal. Okay, we're getting a little bit further than just this one question, but procedural anxiety, investigation-induced anxiety, I'm not sure. Samina, if you can look that up, if this is investigation-induced anxiety, if that is an LLT, maybe. Breast cysts, okay. Anticipatory anxiety, there's one, a different one. Mammogram, okay. All right, it looks like lots and lots of people are agreeing on procedural anxiety here. So with that being
Which
said,
term did you want?
I was just, if you have a chance, if you can look on your screen instead of me pulling the browser over right this second, I was just curious, this investigation-induced anxiety, is that in our, I don't think we have that in our browser, but we can check. I just want to see if it is in there. Okay, so we're getting lots of different responses, which I'm actually very happy about. Everyone's engaged and
Yeah, there's no term.
okay. So we'll, I'll give another second or two here. Just make sure everyone had a chance to put their guess in. And actually, I'm going to keep that open so we can, I'll keep them coming. But in this case, for how would we code the patient experience extreme anxiety due to upcoming mammogram, I went with the response of anticipatory anxiety. And I saw one person did choose that. And the reason why I went with anticipatory anxiety rather than say a procedural anxiety is because the procedure hasn't yet taken place, right? The anxiety is around, you have an upcoming mammogram and you're kind of sitting at home and in your own thoughts and you're anticipating what's going to happen or what results you might get, and how that is a scary time for a lot of people, you know, waiting to get their mammogram or even to just go get a mammogram. There's anxiety around it. So I chose anticipatory anxiety, but I'm actually happy a lot of people did choose procedural anxiety, because if you think about it, it is kind of related to a procedure. It's not during the procedure per se, but this is an example where I put the correct response might be anticipatory anxiety, right? But then other people are saying, okay, maybe it's, I would prefer to go with procedural anxiety. Why would I not choose that? And it is a good choice and that's something where maybe your organization, you know, within your organization, you would have to say, okay, we deal with a lot of breast cancer. You know, we're in the oncology realm, and we're specifically in the breast cancer realm. And we deal with a lot of these type mammogram situations where, you know, patients are constantly every 6 months going get their mammogram or whatever the case may be. And there may be anxiety around it. And we would like to, instead of going to anticipatory anxiety, we would like to see these terms coding to procedural anxiety, right? So this is a great example. It goes back to what Samina was saying earlier, where sometimes, you know, there's not just a clear-cut answer. And then also what Samina was mentioning earlier, where coding conventions really can come into play here, because this might be something where your organization says, okay, we want these to go to procedural anxiety. So we will put a coding convention around it, and that will help to keep everyone on the same page and these coding the same way, right? So it's something to think about and keep in mind as you go through the process of coding, of, you know, dealing with different types of terms. And in this case, I gave you my reasoning why I went towards the anticipatory anxiety route, I should say. Okay, so moving on, now we will get into coding for the rest of the pieces of the narrative that we pulled out. So let's see here. Okay, good. I'm glad to see it's coming up. I will activate this. So now I would like if everyone could give me, you can number it 1, 2, and 3 LLTs for how you would code. Firstly, the mammogram resulted in architectural distortion. Secondly, small breast cyst. How would you code that? And then thirdly, the follow-up MRI showed no suspicious tissue abnormalities. So please select an LLT for each numbered event. And let's see what we come up with here. Okay, so I see we have very quick response here. Mammogram abnormal, breast cysts, and an MRI normal. Okay, we'll give everybody a little bit of time. So this one, especially since there are 3. Looks like lots of people in. And as you can imagine, you know, we saw from our map earlier, my favorite slide in the whole presentation, but we have people from all over the place representing this. And it looks like here we have a lot of people coming together from, you know, to choose kind of the same types of terms. So this is great. All right, we'll give a little more time here. All right. Okay. I know this because especially since there's 3 and it takes time to browse, so we will, you know, definitely give a little more time. So Samina, just curious, not to put you on the spot, you can say you don't have a response if you choose not to. But since while we're waiting for everyone to get their responses in, for the anxiety type term, would you have gone with the anticipatory, procedural, anything else, or?
I'm actually looking at that. So under anxiety, I would have actually agreed with the way you did it and not done the procedural, because to your point, the procedure has not occurred yet. So I would have gone with the anticipatory anxiety as well.
Okay, good to know. All right, now we're getting lots of responses, and thank you. And I'm sorry, I don't mean to put you on the spot. Just figured we have a little dialogue while we wait to see. And I was curious to see how you would have went, because yeah, I mean, just because we work together, you know, we can also have differing opinions on how things can be, right? At times, breast complication associated with device and breast cysts and MRI normal, still MRI normal, mammogram abnormal. Okay, twice, and a breast cyst. Okay, we're getting lots of similarities, some differences. Mammogram abnormal. Okay. Normal. Wow, lots of responses. I love this. Thank you, everyone, for being so engaged. Magnetic resonance imaging breast normal, breast cyst and mammogram abnormal. Architectural distortion. Okay. All right, looks like the poll may be slowing down. So what I'll do is I will pull this over. And I will continue on with the actual slides. Okay, so here we go. So here's what I chose. So the mammogram resulted in architectural distortion. That one, I would suggest going to LLT mammogram abnormal, which many of you have chosen. Because if you pull the browser over and you search here for a term like architectural distortion, I'm sure many of you did, you see it's not available in here. So the choice so the best choice we do have for this, because what exactly is architectural distortion? It just refers to an abnormal tissue pattern, right, on a mammogram. So in this case, the best LLT, the closest match we have from an LLT standpoint would be to capture the abnormality of the mammogram. So job well done there if you went with mammogram abnormal. And then the small breast cysts, I think mostly everyone had that, or it might have been 100% of people had that going to the LLT breast cysts, so very well done. And then the last part, the follow-up MRI showed no suspicious tissue abnormalities. That did see one person actually had that, the LLT of magnetic resonance imaging breast normal, because in this case, it came back with no suspicious tissue abnormalities. So the follow-up MRI actually came back normal, right? But in this case, I'll go to my next slide. I actually have a browser tip for you, because I often get asked, when I'm doing my face-to-face, or just when we're doing webinars, or just really at a user group meeting or anywhere we are, like, what are some tips on the browser, right? And that last piece of that narrative is a great way to show you a good tip, because I did see lots of people went in and they did what I'd say would be the normal thing to do, right? You see that there's an MRI, so you type in MRI, and you're going through and you're looking and you say, okay, yeah, MRI, all right, we have a normal, perfect, because there was no suspicious tissue, right? So the MRI was indeed normal. However, this is a case where you might want to look at the PT and say, okay, I see here the PT is not MRI, it's magnetic resonance imaging, right? And I would say one big browser tip is always try to go in and do different variations of the term to try to find what you're looking for, right? If you don't find it the first time, maybe try something else, and just to make sure that that there's nothing else available, right? So I would say, okay, go in and do magnetic, and then I just do snippets of words. That's another tip I give. I don't necessarily need to type in the full word. I just do a snippet because I like to see what kind of would pop up from there. And I clicked on it, and as you go through, you can see here that when you pull up the full word instead of the actual medical abbreviation, that there are many more options available. And here you can see that there is a breast option available, which is in the realm of what we were talking about, right? And then you could see here that there is indeed a breast normal available. So that's kind of where you would go in and how you would have the process behind how I would handle coding that. And a little browser tip for you too, which some of you may know, some of you don't, but sometimes, it does get tricky using the browser, and it is important to keep in mind that there are, it is always a good idea to kind of do different variations, kind of snippets of words, do abbreviation, then type out kind of pieces or the full word itself. So just to, make sure you fully are searching fully on the word. Okay, so just again, there's the final suggestions, and there was no architectural distortion available in MedDRA, so we went with the abnormal. Hannah, I'll just take a brief pause before I go into my next example. See, are there any questions around this?
I am not seeing any more questions in the chat.
Okay, great. All right, so we'll move on to example 5. I almost said 2 because it's my second one, but we'll move on to example 5. So now let's take a look at a more straightforward term for coding, right? A type of term that would be present, say, in both clinical and safety databases. So we have seasonal allergic conjunctivitis. You might say, oh, that seems really easy, right? We'll see if it is. Maybe it is to some people, maybe it's not. But we always say, again, you always go through, kind of when you see a term like this, go through, is it clear? Is it something that needs to be split at this point? Seasonal allergic conjunctivitis, I would say, maybe, maybe not. I mean, you know, as I'm going through the process, I just kind of think about it, you know, what might be the most appropriate LLT? Would it be something that requires more than one LLT? And actually, for those of you in the northern hemisphere right now, some of you may even be experiencing this, right? I know my allergies are terrible right now. It's allergy season. But anyway, let's pull over the pull everywhere. Let me deactivate this one. Hopefully my next one comes up. Okay, so I will activate this. And what LLT would you choose for that term? So I'm just curious. Let's see what starts to pop up here. Okay, lots of perennial. Okay, we're getting lots of different responses. I like this. All right. Okay, we have lots of allergic conjunctivitis, seasonal, perennial allergy conjunctivitis, seasonal and allergic conjunctivitis. Okay, we've got some people that would split here. All right, I'm just gonna give a little more time, make sure everyone has a chance to go in and put the responses in. Seasonal allergic conjunctivitis. All right, we'll give a little more time here. Okay, so while actually people are putting their responses in, I'm actually going to go to the browser and we'll start to look around here. So I saw, we'll first start with allergic conjunctivitis, right? Because I saw a bunch of that being as answers. So you see here, okay, we do have an allergic conjunctivitis. We have an aggravated. We have, and here's the one some people put down, the perennial allergic conjunctivitis. Let's see where that goes. Okay, it goes to conjunctivitis allergic. So here's another browsing tip in case you know, you're newer to MedDRA and you would like, you can see, Samina was doing a lot of this during her slides as well, where we, you know, it's very second nature to us, but to some people you're not aware, but you can click these and kind of get the MedDRA hierarchy right in front of you right here. So you could just keep opening the plus to a minus, and then you'll see the MedDRA hierarchy. And you could see here that this falls under the PT conjunctivitis allergic, and then under the SOC or SOC system organ class of eye disorders, right? With a secondary linkage to the immune system. But then you can also right click on this term, allergic conjunctivitis, and say, go to browser, and it would pull up this. And then you double click on that and it will take you to the left-hand side of the browser. And you can see here, you can get a better picture of what's available under that allergic conjunctivitis type term, right? Lots of different things available, maybe some that didn't even pull up on this right-hand side when you just typed in your snippet of allergic conjunctivitis. So here you do have, again, we see the perennial allergic conjunctivitis, which was an option. So now, I'd say, you know, okay, we're taking perennial. That's kind of more like a yearly kind of chronic type condition, right? So I want to see, okay, is there anything else kind of available besides just the allergic conjunctivitis? Since this term did also include the seasonal aspect of it, right? So it's seasonal, it's related to the seasons. So what I'll do here is I'll say, in my mind, I would say, okay, let me just look at conjunctivitis as a whole, right? I'll do a snippet of conjunctivitis. I'll go in, I'll see what pulls up. And then I'll just really, as simple as it seems, I'll just go through all these terms and see, is there anything else maybe that might fit? I'm doing it really fast here just because we are in a presentation. But, you know, if I was at my desk kind of doing this, or in my home, in my, you know, on my computer kind of looking through, I would take my time and just say, okay, let's see what else there is. So here you see, I stumbled across seasonal conjunctivitis, right? Okay, that might be something I'm interested in. So I'm gonna open this up, see what's available, see what goes underneath. All right. This actually has links to multiple system organ classes, but you see here, the PT seasonal allergy goes into the HLGT allergic conditions. All right, that's something good too, because it was seasonal allergic conjunctivitis, right? So I'm actually going to right click on this term and go to the browser and see where this ends up. So you see here, it's under the seasonal allergy type term, along with hay fever, pollen allergy, etc. So in this instance, everything we needed was captured in this one term of seasonal conjunctivitis, right? Because it does link into the seasonal allergy. So you have the allergic aspect of the term also captured under seasonal allergy. So in this case, you know, I think everyone knows where this is going, but let me pull this back over up. I see here now people are starting to respond. Very good. Lots and lots of responses. I like that. All right, I'm actually going to deactivate this poll so it's ready for my next one. But as we go through here, we did browse, we went through, we saw the process around it. But there you go. The correct response would be seasonal conjunctivitis, which links into the seasonal allergy. So that's just an example. I know it seems fairly simple, you know, kind of example, but it's just to show you that actually browsing and taking the time to do snippets of terms and see what else is available in the MedDRA dictionary and where actually that would end up, right? Because in this case, if you did code the allergic conjunctivitis, like I showed, one second, let me just pull my browser back over. It would end up at the PT. I forgot what the PT is, forgive me, but I think it's the same, right? No, conjunctivitis allergic, so similar. Whereas the actual response here ends up at the PT seasonal allergy, which could make a very big difference from an analysis perspective, right? If you're looking for all instances in your database where your patients had a seasonal allergy, and you coded that term to say allergic conjunctivitis, this would then be missed in your analysis of seasonal allergy type terms. So it's just something, or if there's a flag in your system and you're flagging every patient that has a seasonal allergy, right? And when we flag and we do data analysis, it's done at the PT level. Something like that would be missed. So again, just stressing the importance of why it's so important to kind of look around the MedDRA dictionary, and it's so large and there's so much information available in there to always just kind of do your snippets and see what's available. So there you go. Okay, and I see the time here is 12:12. I am going to go through my last example, and then if this goes a little bit over, hopefully I'll get done before 12:30, but I just want to, at the end, just make sure we have a little time to get feedback from everyone. So if everyone could just stay on the line, just in case. But let's get started here, so hopefully we don't go over. Okay, so the patient, my next example, example 6, is the patient took an antibiotic and experienced a full body rash. The physician recommended a D-challenge and the rash disappeared. The antibiotic was re-challenged and the rash came back. So there's a lot going on here. You might say, what do I do with a term like this? Again, well, the first thing to do is break down the term like we did in example 4, right? Then as usual, go through the questions, kind of list it. I'm not going to break this down the way I did the first one because we already saw that today. However, in this case, what I did was I started referencing what the actual information inside the term meant, right? To make sure I'm kind of guided in the right direction for where I want to go to code these terms, or this term, or this case, right? So in order to properly code the term, it's important to fully understand what is being reported. So since the term specifically mentioned D-challenge, it's important to reference what a D-challenge actually is. So as you can see, it's the stopping of a drug after an AE or at the end of a planned treatment. It's also important to note that D-challenges can be complete or they can be partial. So the drug is fully stopped or decreased in dose and the AE completely disappears, right? So checking the term, it states that the AE did disappear after a D-challenge, which from the reference information above would be considered a positive D-challenge, as you can see on this slide. And it's also important to note because sometimes even, investigators or the monitors, whoever is sending this information in, may get it kind of confused and you don't know. You may get a D-challenge and you still have the adverse event, and then you might have to query that to say, okay, is it really Is it a positive D challenge? Is it, you know, a D challenge at all? You know, things like that. So just items to keep in mind. Hence why I make sure I have all the information I need available to me up front. This is why I'll go through and start to reference this and say, okay, I could say, okay, the term is making sense. You know, it is going through, it is a D challenge. So now we're on to re-challenge, right? Because I looked up what a D challenge is. I also want to know what is the re-challenge, right? So now we're looking back at the reported term, and the last part of the term stated the antibiotic was re-challenged and the rash did come back. So you could see here, I not only looked up re-challenge, I looked up a positive and negative re-challenge as well. So after looking at re-challenge, both positive and negative, going off what was reported, and after referencing the meaning of re-challenge, we can see since the rash came back, it is considered a positive re-challenge, right? So this refers to the AE recurring after restarting the drug. So to have this occur, it would have had to previously disappear after the D challenge in order for it to restart, all of which we could say, yeah, that seems just like our event here, where the patient took the antibiotic, they experienced a full body rash, they recommended it and it disappeared, then they re-challenged and it came back. So here we have some concepts to be coded. So the patient took an antibiotic, experienced a full body rash, where would that code? The physician recommended a D challenge and the rash disappeared, where would that code? And then the antibiotic was re-challenged and the rash came back. So let's pull up the poll. Bear with me. Okay, we're going to activate this and give you a chance to fill in the blank for all three of those terms. Again, you could do 1, 2, 3 if you want, or you could just type them in sequential order or even out of order. Just if you give 3 LLTs for this, that would be wonderful. All right, so first we have the drug re-challenge positive. And remember all the different pieces as well. Just going to give everybody a little time, so I'll be a little quiet here while people are thinking. All right, we're starting to get some responses in, so I'm just going to scroll through so I can see as well. Drug re-challenge positive, allergic reaction to antibiotic, rash all over.
If I may make a comment, for the anaphylactic reaction to drug, remember we don't want to add information that is not given, right? So unless something is expressly stated as a diagnosis, we wouldn't code it.
Good pickup, Samina. I went right past that and didn't even think. Yes, that's very true, right? And that's something you even mentioned when you were presenting, you know, not to, you know, sometimes it's very difficult. I understand. I was in the coding world and the pharmacovigilance and the, you know, clinical world for a long time before I came to the MSSO, and you wear that hat and kind of, it's a little hard to kind of get out of that hat sometimes if you're a physician, right? And you sometimes you automatically go to what you think the diagnosis would be, you know, and sometimes you got to kind of take that hat off and just say, okay, this is what I was given, and this is what how I need to handle it just based off the information written. So thank you, Samina, for that. Good pickup.
Another comment, just as people are doing it for the administration site reaction, that is something that would be worthy of consideration, but yet we look at our example and say, well, is it really administered at a site per se?
Yeah, yep, because it was an antibiotic. But then again, you know, we don't know. It was the antibiotic, could have been a cream, right? Could have been oral, could have been a cream. Do antibiotics? Yeah, they come in cream, right? They could, I think, right? Or am I making that up? Okay. All right. So, yeah, lots of good stuff here. Okay. Drug de-challenge positive, adverse reaction to antibiotics. Okay. Generalized rash, drug de-challenge positive, drug re-challenge positive, rash recurrent. Okay. So people pulling out lots of different information here. Again, it's great because we are so worldly on this call. There's lots of different viewpoints. There's lots of physicians, maybe some, data management, case management, coders, maybe even some biostats. I mean, on the line, we all have different ways that we look at something and we see different things, right? So this is why it's so important to always kind of brings you back to breaking down the term, dealing with only what we receive, and then kind of doing the best with what we have, right? And then if you need to, send a query, etc. But yeah, it just goes to show, you put 20 people in a room together and show them a term and you might get 20 different responses. So another point to take back to why coding conventions, data management conventions, things like that are so important, right? Because it helps to bring you all everybody to the same page. Okay, when you look at this, this is what we will interpret it as, right? So there's no room for kind of, all different types of interpretation. All right, rash all over, drug D challenge, drug read challenge. All right, so with that being said, I see lots and lots of responses. I think it's kind of starting to slow down now, and it is 12:21. So I will pull this over and I will say, this is the route. These are the LLTs I chose. So the first piece, the patient took an antibiotic and experienced a full body rash, goes to drug rash. I did not choose the allergic piece of that because it doesn't say necessarily an allergy occurred, right? If you look here, we see drug rash, allergic drug rash, they go to the same PT anyway, but in this case, there was no mention. I mean, you could assume maybe, yeah, an allergy did occur, but because it's not stated, just simply go with drug rash, right? The physician recommended a D challenge and the rash disappeared. So based off of all the referencing we did earlier, we can say, yes, this is a drug D challenge positive, right? And then the antibiotic was re-challenged and the rash came back. So that's a drug re-challenge positive. And the way we know that and why it was so easy, we could go in then and just go in the browser and look for what we want to look for. Like in that case, we did our referencing, we understood it was a positive. We can go in and just kind of type it in and get the term we need. So the LLT, drug re-challenge positive. So great job, everyone. Wonderful. It's great to see everyone participating. And so those are my final suggestions on here. And Hannah, before I move on to our last poll of the day, I just want to take a minute to see if there were any questions around that.
I am not seeing any new questions in the chat.
Okay, great. So what I will do now, we have a couple minutes. Samina and I would appreciate it very greatly if we can get some feedback on today's presentation, as well as what you would like to see in the future. Because what Samina and I like to do is we take these suggestions we receive in this environment, and then we actually build our slides and our presentation off of what you all suggest. So we like to get some suggestions for future. We enjoy it, and then we can also help to go through if you have a challenging term or concept or even area of Medra that you would want us to focus on. Let us know, and then we'll make sure we incorporate that, or we'll try to at least incorporate that in the next Let's Code Together that we do. So with that being said, while we wait for some feedback or some suggestions, hopefully this is working. Oh, there we go. Yay. I thought maybe I went the whole time with no glitches, which I can't believe after, having such a troubling morning with this. And then I thought maybe it wouldn't work on the last one, but yay, we made it all the way to the end and it worked the whole time. I'm so excited. But with that being said, I would just like to say a big thank you to you all for joining today's session. I think I speak on behalf of Samina as well, and she can also say her thank yous when I'm done. But we appreciate you all. We know how busy day-to-day becomes and is, and we appreciate you all taking 90 minutes out of your day to listen to us and to go through these Let's Code Together examples with us. We really appreciate it. We hope to see you at a future Let's Code Together. Well, at least virtually see you at a future Let's Code Together session, or at least interact with you, I should say, not see you. And also, maybe we hope to see you at a future face-to-face class. There is one coming in the U.S. Hannah could correct me if I'm wrong. I think one just passed. I don't think the one that was located in Boston, I think that's already done. Right, Hannah?
Yes, that was last week.
Okay, so the next one coming up in the U.S. will be in the Midwest. So if anybody's interested in going to the Chicago area in June 6th and June 7th, I believe it is. Hannah, again, she can correct me if I'm wrong.
June 6th and June 7th.
Okay, yay. I got it right because I should get it right because it is my face-to-face. So I will be there in the Chicago area for anyone who would like or can attend, or if you know colleagues that you think it would be good for them to attend, send them along. It's free to everyone. You just have to sign up and travel out there if you're not in the Chicago area. But thank you so much. It's Samina. I'll give you a chance to go through if you want and see. Yeah.
Yeah, we also are having a user group meeting in June in New Jersey area. So that's something else. People, if they're interested, they can come meet us live. We'll be there. And I see that we have lots of suggestions for the next Let's Code Together session. People want more frequent sessions as well. We've seen requests for drug interaction cases, procedure-related cases, and we certainly will take heed to this advice and have these types of examples in the next session. Okay, well, good. We're very pleased with the positive feedback. Thank you very much.
Thank you. And maybe, you know, as these sessions grow, we can maybe even open it up. A couple more people, you know, come. We'll see how it goes. But this is great. Okay, so 27, just a suggestion. Okay. We could do future terms and stuff, and we'll also take this drug interaction. And yeah, thank you for all the positive feedback, and I'm glad everyone enjoyed it. All right, with that being said, Hannah, one last check-in. Are there any questions from myself or Samina?
No questions, just a couple thank yous being sent in the chat.
Excellent.
Oh, great. All right, so with that being said,
your final URL slides.
Oh yeah, I'm sorry. I can also give you, you know, the final slides. That would help. So here's just some final takeaway slides just with our information. So if you have any problems, you can always email the help desk. We have the medra.org, frequently asked questions. We have the link to the browsers that Samina went through earlier for all of you. The training schedule, so you can take a look and see when our next Let's Code Together session will be, and you can sign up and join us. And then we also have a link to the YouTube channel, which Hannah mentioned earlier, that this will be recorded and available on the YouTube channel. I don't think there were any audio issues. So this should be available in the coming days, and you can go back and look at the YouTube channel and, you know, look at this presentation again in the future. If you forget anything or you want to just see it again, you know, it's always helpful to go back and look at things. And with that being said, we're going to close out the session today. And again, we thank you all for joining, and we wish you all a happy rest of your day. I was going to say almost at the weekend, but I forgot it's only Tuesday. I was thinking it was Thursday. So we do have a little bit to go in the week, but hopefully everyone enjoys their day and enjoys the rest of their week. So thank you all.
Thank you, everyone, for the positive feedback.
Bye-bye.